Assalamu alaikum. First, I would like to thank the organizing committee for this exceptional meeting. It's really an honor and for me to be here today. And so I had the task today to present for the first time the characteristics of scleroderma in the Arab countries. This is the first time to present the United Arab of Emirates scleroderma registry. I have no disclosures, and so as we know, systemic sclerosis, also known as scleroderma, is an orphan disease. It's a heterogeneous disease characterized by vasculopathy, inflammation, and fibrosis. It affects multiple organs, including mainly the lungs and the skin and the heart, and it has high mortality and morbidity and mortality. So for a fact, we learned that it's easy to diagnose scleroderma, but still we're challenged in diagnosing scleroderma. So if you have Raynaud's phenomena, if you have sclerodactyly, and if you have a positive ANA, confidently you can say that you have scleroderma. But still there's challenges in early diagnosis of scleroderma. We know for a fact that there's racial differences exist, both in susceptibility and severity of scleroderma. And for a fact, we know from the American registry that African Americans have a higher age-specific incidence and prevalence of systemic sclerosis. And it ranges from 14% in the US, and in Canada it goes up to 34 to 35%. However, most of the available data that we have in the region comes from Europe, North America, South America, China, and the United States. So why scleroderma? Why did we think of establishing a registry? And this is, I think this is more for junior colleagues here, that I think in 2017, I moved to the United Arab Emirates. I've been involved in scleroderma since 2012 with Professor Dinesh Khanna. And this triggers me when I moved to the UAE. I was wondering what's the prevalence of the disease. And these are patients from my clinic, and as you can see here, that you see a lot of pathology in our region, and not only pathology, but you see a lot of complexity of the disease. And you can see here that on the left side, this is a puffiness of the fingers, there's calcinosis, advanced digital ulcer, morphia on the right mid. This is a severe calcinosis of one of my patients, and you can see here a very burned out disease, scleroderma in the middle, and there's another picture of calcinosis from the right thumb. So with this, our triggers, the thought process was, let me look into the literature. Let me see what's available in the literature, locally and internationally. And for a fact, we know that there's a lot of literature from the US, from Maureen Mays, there's from Professor Denton in the UK, and from other colleagues in the region, from Brazil. There's a lot of cohorts in the region. And just in the region, there's three main papers. One was from Qatar, from Dr. Samar's group. It was a very extensive describing the characteristics of systemic sclerosis. There's another study from Libya, from Benghazi, and there's another study from Saudi Arabia about morphia. So we're lacking, there's paucity of data in the region, and that was one of the reasons that triggered us to establish this cohort. So there's paucity of data regarding demographics and treatment response to scleroderma. So we sought to gain insights on the clinical and serological features, including the demographics, comorbidities, autoimmune profile, and other their treatments. And it was a comprehensive, data collection. We also sought for the first time to estimate the prevalence of the disease in the country, and also we thought the prevalence of interstitial lung disease and pulmonary hypertension. So this was the roadmap of how we initiated this process. We under the umbrella of the Emirates Society of Rheumatology, we met and we spread the word of establishing a United Arab Emirates scleroderma registry. We applied for a IRB at our hospital, and we said, let's start from our center. Let's start from Cleveland Clinic. And we collected about 100 patients. And then we went again to all colleagues in the region by different meetings through the ESR, All colleagues were appreciative and were helpful to, I think without them we couldn't establish such a registry. And then we went again to the ESR and they gave us a grant to publish this. So it was a very comprehensive teamwork from 2018 and we just finished it in 2020-21. So everybody in this, I think maybe there's some missed doctors, but everybody in this list significantly is involved in this registry from multiple hospitals in the region. And really, I'm thankful for all their time. It's a time-consuming, you know, and it's time for their busy clinics it was a comprehensive teamwork that was really appreciated. So what we did, it's a retrospective cohort, clinical characteristics review. We collected 190 patients, and it was a comprehensive data collection. We did statistical analysis, multiple statistical analysis methods, and as you can see here, we were more interested in the local data. We know the, you know, there's registries from other countries, so we focused mainly on the UAE. We had 104 patients, 54% of the registry was from the UAE, 23.7 was Arabs, non-UAE, and 21.6 were non-Arabs and non-UAE. They were expats. Very interesting data. So we looked first at the age of presentation, and as you can see here, limited cutaneous was the highest, 49.4, followed by diffuse cutaneous sclerosis, diffuse cutaneous, and morphia was the third. And we thought maybe this is due to the challenges in early diagnosis limited cutaneous sclerosis. If you don't have sclerodactyly, we see this in the region, so sometimes this diagnosis is missed. This was followed by the time between the first non-Raynaud's phenomena until the diagnosis, which takes about 6 to 5 years. And this raises the question that more awareness is needed in the region and more to primary cares, primary rheumatologists and patients also. And as expected, it was more seen in females. Highest was a limited cutaneous systemic sclerosis, was 8-1, followed by diffuse cutaneous systemic sclerosis, and morphia was 3.6. A majority of our patients were from Abu Dhabi. This is the first time we assessed the prevalence of the disease, and it's as shown in the table on the right side. So we looked at the whole registry, and then we divided it just to the patients from the UAE, and you can see here diffuse cutaneous systemic sclerosis was 3.8%. Higher was, marginally higher was in limited cutaneous, 3.9, and morphia was 1.2. And as mentioned earlier, that I think this is the least in the geographically among different countries. In the US, it ranges between 14 to 20%. I think in Canada, it goes up to 35%. We also looked at different patterns. We looked at patients who had a pulmonary hypertension without ILD, ILD without pulmonary hypertension, and we also assessed the prevalence, and as shown in the table, the prevalence of ILD in patients with systemic sclerosis was 3.37, followed by what was lower in patients with pulmonary arterial hypertension. It was 0.17, and if you have both PH and ILD, the prevalence was 1.12 per 100,000 individuals. We looked into comorbidities, and I just highlighted the most significant ones. Smoking was higher in patients with diffuse cutaneous systemic sclerosis when compared to limited. Diabetes also was seen more in limited versus diffuse cutaneous, and GI symptoms were higher, as expected, in patients with limited cutaneous systemic sclerosis, and iron deficiency anemia was higher in patients with diffuse cutaneous. And you know, numerically, you can see that there's some differences, but didn't achieve statistical significance. We looked at their immunological profile, and again here we see some differences. More patients with diffuse cutaneous with limited cutaneous systemic sclerosis at the positive NA compared to diffuse cutaneous systemic sclerosis. I think, and we did comparison with other cohorts, and we see some differences. And as expected, centromere was higher in the limited group versus the diffuse group. CK was higher in patients with morphia when compared to the other two groups. And SCL70, as expected, was higher in the diffuse group. anti-centromere was more, and this replicates the other cohorts, that this is more a legitimate or a similar cohort to what we see in the internationally. And we looked for other parameters, other immunological parameters, including U1 RMP, RNA3 polymerase, but we didn't see any statistical difference. We looked at their clinical manifestations. We saw that the fatigue, sicca symptoms, Raynaud's, and sclerodactyly were higher in the diffuse group versus limited. There was also differences in telangiectasias, more seen in limited versus diffuse. Joint contractures were, as expected, more in the diffuse group. And we also looked at symptoms such as cough and shortness of breath, which were higher in patients with diffuse versus limited. ILD, as expected, was higher in the diffuse group. And also we did the same exercise where we looked at pH, ILD, with ILD, pH, and versus and ILD, and about 8% of patients in the limited cutaneous systemic sclerosis had ILD and pH, which was something that took our attention. We looked at their medications. We looked at the immunosuppressive medication use. Methotrexate was used more in patients with limited cutaneous versus diffuse, and it was also used at higher proportion in morphia. MMF was more used in the diffuse cutaneous systemic sclerosis group. There's a couple of patients that we use tocilizumab and rituximab, and we use a lot of antifibrotics, including pirfenidone and nintedanib. We did the first plot where we looked at what are the main representation of clinical manifestations. So if you go to the right side, it's more limited cutaneous systemic, diffuse cutaneous systemic sclerosis, and if you go to the left side, these clinical manifestations are more common in the limited cutaneous systemic sclerosis. And you can see that there's differences. It helps to delineate or differentiate both diseases. With this, as yesterday Dr. Hanan said, there was more to come. This was not the final step. We went further and we communicated with all colleagues in the region, and we were successful to recruit 1,000+ patients. So the next step is we approached all physicians, colleagues in the region, approached Jordan, Dr. Hani Shatnawi, who was kind to share his data, Lebanon, Dr. Imad Uthman, and Dr. Fouad Fayyad, from Saudi Arabia, Dr. Muhammad Umair, Dr. Walid Hafiz, Dr. Hanadi, from Tuam, Dr. Imad, Dr. Ahiba, Dr. Khalid, Dr. Ziyad, from Mediclinic, Dr. Anada, Dr. Amal, Dr. Fahad Athir, Dr. Hazem, from Dubai, Dr. Jamal Saleh, and from Sulaiman Habib, Dr. Jamal and Dr. Walid Shahi. Dr. Suad Hannawi also was part of this. And from Yaz, Dr. Ziyad, Dr. Abhai from Burjil, Saudi German, Dr. Abu Gamal, Bahrain, we have Dr. Saadiya, Dr. Sahar also was kind to share her data. From Qatar, we have Dr. Samar and Dr. Karima. Dr. Adiba recently and Dr. Aqil were kind also to help with supporting this project. From Oman, Dr. Farida. From UAE, Dr. Humaira and Dr. Ahmed Zayat from Sharjah. Dr. Shariban, she's the head of rheumatology at SSMC from Iraq. And from last but not least, Dr. Muhammad Al-Marzougi from SKMC. So hopefully maybe next year we'll have, or end of this year, we'll have more data to present. We have more to come, and inshallah we'll share with you this data. It's a very elaborative teamwork that honestly I want to thank everybody who participated in this. Without them, I won't be here sharing this data, and I would like to thank my team for all their support. And with this, I would like to thank you for your attention. Thank you very much.